Thank you. Oh, how do I do this? Thank you. Never again will I present. Terrible idea. Don't know why Adam talked me into this. So I'm Lauren. I'm a general paediatrician from Cairns Hospital, and I was just going to give you a few updates from the neonatal world that's hopefully relevant to your delivery room, whether that's the back of an ambulance, the back of someone's yard, the ED room, or wherever. So we'll start off by looking at a few old things, such as oxygen use in the delivery room. These things keep coming and back and going away, but they're still changing in our latest guidelines. We'll talk a little bit about some of the newer things to neonatal medicine that are probably quite old to you. We'll talk about a few things that we've borrowed from you guys, or from the adult medicine literature, and we'll just finish talking about some blue babies. So starting off with the initial amount of oxygen that you need to use in your neonatal resuscitation. So this is something that's changed dramatically throughout the last few decades in the century. In the middle of the century, we found out that give too much oxygen and you give babies retinopathy of prematurity, so we dialed it right back, and then we found that we're giving babies cerebral palsy and causing high mortality rates. So this pendulum has continued to swing, really. And we're not really sure where we need to end up, because we're not really sure what targets we should be aiming for. All of the data from that comes from healthy term babies. So it's an interesting space because neonates are a unique population in that they're really sensitive to both hyperoxia and hypoxia. So the current recommendation has pretty much stayed the same for a while, that we resuscitate term or close to term babies in air to begin with, and for the preterm population we can choose somewhere between 30% and air. The recommendation stating that we shouldn't start in 100% has recently been removed, and resuscitation now for less than 32 weeks can be in more than 30% if you choose to. And this is really from a big meta-analysis, so the Net Motion meta-analysis, which was published in 2022. And that looked at over 1,000 individual neonates data. They were all less than 32 weeks, it was from 12 different studies, and they compared babies who were initially resuscitated in high oxygen, so over 90%, which is wild, between 50% and 65%, the intermediate group, and the low oxygen group, which was less than 30%. And they actually found that when you compared the high and the low groups, that the high group did a lot better from a mortality perspective. So that's slowly changing, I guess, the acceptability of oxygen use and liberalising that in the delivery room. And I think it's relevant to low resource settings, or settings where you just have air or 100% oxygen to choose from and no oxygen blender, to say that, well, maybe it's okay to start in 100% oxygen. And I think, it's particularly interesting that there was no difference in those groups between people with, in terms of the rates of chronic neonatal lung disease and retinopathy of prematurity, which we were really worried about from a hyperoxia perspective. The other study that's kind of interesting, because it's Australian and it's looking at these moderate to late pretermers that we see lots and lots of, and it was a crossover study, over 1,000 babies, looking at starting resuscitation in air versus 30%, and we found that the babies who were resuscitated in 30% did better from the perspective of needing less invasive respiratory support, and that actually most babies need more than 30% anyway, so what are we so worried about? Delayed cord clamping is something that has also been around for centuries, and we've swung back and forward with this as well. This is a really nice picture, I think, from Anoop Kathiria, who's one of the big advocates from America for delayed cord clamping. He's done heaps of research. This was published in 2016 in the Journal of Neonatology, and it just goes through the pathophysiology of why we do delayed cord clamping, which makes a lot of sense. So after the baby's born, you have the uterine contraction, which forces the blood down through the umbilical vein. the negative intrathoracic pressure draws that blood in, and the natural spasm of the umbilical artery stops it from going back out. And so you get this natural placental transfusion, which is providing a good amount of, stabilising cardiac output, and that's what's really reducing risks of big problems like intraventricular hemorrhage. So it's stabilising that cardiac output by giving a big preload. And then there's also positive things that are happening down the track. So prem babies are needing less red blood cell transfusion, and term babies are not having so many problems with anemia and iron deficiency. So in 2021, delayed cord clamping became really the mainstay for newborn vigorous babies, and reduces death, so necrotizing enterocolitis, IVH, and need for transfusions without causing harm. So the next group of babies that we're looking into are the non-vigorous babies at birth. So what should we do with those? And there is weak evidence now that we can actually go back to cord milking in preference of early cord clamping for these term and late term babies, and that they did really well. And down to 28 weeks, actually, these babies didn't have any adverse outcomes. Cord milking was a little bit weird to me when I first heard about it, but I have a wee video here that might work. I'm not sure if anyone does this routinely. Oh. So that's kind of what it looks like. But you get a 20 to 30 centimetre chunk of cord. While it's still attached to the placenta, you just squeeze that 20 to 30 centimetre chunk over 2 seconds, and you do that 4 times. And so that's intact cord milking. If your cord is already cut, you just do it once. And that's just because the placenta can't refill the umbilical vein, so you don't get as much transfusion, but it still does the job. So that's come back into our guidelines, which is really interesting. Okay, so moving on to something new. So supraglottic airways, they've been around for a little while, but they've kind of rusted in our resuscitation kits. We don't tend to use them very much in neonatology, despite them being used a lot in adults and kids. But now that we're intubating less and less babies since the 90s, when we started to give women antenatal steroids, and now that we use a lot of non-invasive ventilation in neonates, we are looking to, find something that we can use in resuscitation and to administer surfactant that doesn't require the skill of laryngoscopy, because we're getting really terrible at it and don't have good ways of upskilling, I guess. So I guess the main limitation to using supraglottic airways in the neonatal population has been the size of the baby and the LMA. So they're only on label down to sort of 34 weeks and 2 kilos, but some of the studies now are actually looking at using them in even smaller babies, even those size 1 LMAs. So it's potentially an interesting space. So in the 2015 guidelines, we were okay with using a supraglottic airway when we couldn't intubate, and that was thought to be okay. And now, if we're not getting a great seal with our face mask, using a supraglottic airway rather than going straight to intubation has now been recommended in the ILCL guidelines from 2022. The most recent ILCL guideline from 2025 suggested that actually you could use a supraglottic airway during chest compressions, and that's probably going to be as good as intubating. And that data comes from animal studies where they have compared the two and found that similar numbers of animals achieved ROSC in similar time frames, and that the parameters like PIP and PEEP and tidal volumes were the same between the two. Interestingly, a retrospective observational study actually found that babies having chest compressions who had a supraglottic airway placed rather than endotracheal tube actually did better. They were more likely to survive, and the supraglottic airway group had better neurologic outcome. So that's kind of interesting. So the other main reason that we give that we need to put in more of a definitive airway in neonates is to give surfactant. And over the last few years, we've had lots and lots of different studies looking at less invasive ways of doing that, but it's still required babies to undergo laryngoscopy. So to experience the discomfort of that, have the risks associated with laryngoscopy, and also to have clinicians who are skilled in that. So the main techniques are like inshore and mist, where you have a look in with your laryngoscope, you thread a little feeding tube down and put the surfactant through the vocal cords. So that's been good, and that does work really well in a select group of babies, but still requires us to be good at laryngoscopy. So we've started to look at whether or not we can just give surfactant down LMAs, and so far it looks kind of promising. They're doing studies down to even 800 gram babies, which is really good, and finding that if we have a cohort, so for example the Roberts study, if we have a cohort that we're either going to just leave on CPAP and see what happens versus give surfactant through the LMA group is doing much better with less serious outcomes. So I think one of the definitive trials, hopefully definitive-ish trials in this area, will be the SURF-SARP trial, and that's just over halfway recruited. They're going to get over 1,000 babies, and that'll be comparing surfactant administration through the LMA versus sort of temporary intubation and surfactant administration. That'll be for babies with respiratory distress syndrome down to 1.25 kilos, and hopefully we'll have some really good data from that soon that we can make more firm recommendations on. So borrowed things. This is about using nasal high flow to support neonatal intubation, and also supportive evidence for video laryngoscopy in this population. Again, this is because we're not very good at intubating babies anymore, and that it is a high-risk group to intubate. Going from, your first pass success rate being related to only a 3.6% chance of having an adverse event versus 35% if you have 2 or more goes. These babies are very vulnerable to hypoxia, they have high metabolic rates, they have low functional residual capacity, and so trying to streamline this process and support the babies as much as possible is really important. So the 2025 ILCOR guidelines really suggested that you should use a video laryngoscope rather than direct, and that's supported by some good evidence from 2024 where they found that we were much, much better at intubating babies with a video rather than directly. It's an interesting study they did just to kind of prove that point on mannequins. So in 2025 they looked at 32 different practitioners. About half were experienced and half were beginners, and they got them to intubate mannequins with direct versus video laryngoscopy, both at the umbilical height and at the xiphoid height, and they found that the forces that were applied to the mannequins were much, much less using video laryngoscopy, and also when the table was more at the umbilical level. It was interesting that the participants thought that it was the opposite way around. So high flow, again, something that's been used a lot in adults and in more older paediatric populations. Now we've had a look in the neonatal population and found that we get an extra 10 seconds to time to desaturation. And so with a much higher success rate, so going from 50% to 30% if you don't use high flow. So these babies were above 28 weeks, and they were started on high flow of 8 litres per minute, and whatever kind of FiO2 that they were on prior to the intubation attempt. So that's something that will hopefully come more into our practice with time, and there's certainly studies going on at the moment looking at nasal CPAP and whether that's more effective. So just finish up going through some assessment of blue babies and what you might do for them. So in terms of your assessment, Firstly, looking at the airway patency, so some babies can have really small and backwards pointing chins with massive tongues, and those babies will obstruct their airways quite spectacularly and early on. These babies do really well prone, so putting them with their face kind of to the side on their tummies will often really help to alleviate that obstruction. And then using your usual airway adjuncts, particularly nasopharyngeal tubes, can be helpful for them. Having a good look around the beard distribution for skin lesions, particularly hemangiomas, can be useful as well. If you have skin lesions in that area, you probably will also have them in your airway, so that can give you a clue. In terms of pulmonary causes of cyanosis, I think they're mostly pretty obvious, and I think in terms of assessing them, transillumination can be really helpful for detecting pneumothoraces. So that's the picture down there. So you can use a like a vein finder or your cyclone torch, whatever. Just put it under the axilla, and the side that has the pneumothorax will be really bright like a lantern. This works better the smaller the baby. So that can help with your pneumothorax. Congenital diaphragmatic hernia is something important to pick up. Unfortunately, you probably only will find it once you do a chest x-ray unless there's an antenatal diagnosis, and this is where the gut contents herniates up into the chest. And the biggest problem is that the lungs don't develop properly, so you have pulmonary hypoplasia and you have pulmonary hypertension, and that causes a lot of problems. It's important to detect these early on because these babies need to be intubated, because if you put CPAP or high flow on, you'll just fill up their guts with air, and then that will make your problem, worse and worse as you go. So these babies, sometimes they come out and they're completely fine, so you don't just leave them alone, but if they are having problems, they need to be intubated. In terms of the C stuff, so mainly cyanotic congenital heart disease, and I think of this as either left or right outflow tract obstruction lesions, where you're needing your ductus to maintain circulation to either side. So if the left side is obstructed, you need your duct to keep the blood flowing that way, and once it closes, that's when they collapse. They will generally always be cyanosed to some degree, but that's when you will have big problems. And then your transposition of the great arteries, so where they're swapped over, and you need your duct to maintain that mixing unless they have a big VSD. So these babies you might pick up because if they have a left outflow tract obstruction, they might not have femoral pulses. Sometimes they will have a murmur, but sometimes not. It's important to do pre and post ductal sats in this population, so either the right hand in the other hand or the right hand in the foot. A big difference is suggestive of persistent pulmonary hypertension, which is what we see in most of our babies who are cyanosed in that acute period, that acute kind of early on period. If there's no difference, it's probably pulmonary, and if there's a small difference, it's more likely to be a cardiac cause. The hyperoxia test is something that can be kind of done in a rudimentary way in any setting, so you just give as much oxygen as you can. Some people would give it in a het box, some babies would be intubated and you give it in that way, but you give 100% oxygen for 10 minutes, and if you have a good amount of change in your oxygen saturation, then it's probably pulmonary. If your sats don't change much, it's probably cardiac, and you just have a shunt that's mixing your sats and not helping you a great deal there. And then other causes of cyanose neonatal really, in terms of neuromuscular disease, so having poor tone or poor effort, intraventricular hemorrhage, prolonged seizure, and the inborn errors of metabolism, which can kind of be nutted out by checking the glucose, the lactate and the ammonia and going from there. My last thing was just to talk about management of TET spells, because it might be something that you come across and can be easily sort of sorted out. TET spells are typically in babies who have tetralogy of Fallot. This is the most common cyanotic heart disease and is in about 5 to 10% of babies with congenital heart disease. The main problem in this defect is that you have some degree of outflow tract obstruction, which is usually in the infundibular area below the pulmonary valve. And when these babies get really, really upset and there's a catecholamine release, that infundibular area spasms, and so your outflow to the right side will be markedly decreased, and you get a big shunt across the VSD. So most of these babies will have a huge VSD. And in that setting, they become profoundly cyanotic and they become more and more distressed, and so the problem kind of self-perpetuates itself. The care is mainly around reducing that agitation and therefore the catecholamine release, and increasing the systemic vascular resistance if you can. So that's the idea of the chest-knee position, is to increase your systemic vascular resistance, so driving that shunt back across the VSD into the right side. And the pharmacologic management is about reducing that agitation. So if you don't have a drip, you can use intranasal Paeds or fentanyl, but IV morphine is probably the most studied option there. All right, that's it. Any questions?
Any questions for Lauren? Oh, a bit shy. Oh, we do have a question. I'll just get a mic to you just so everyone can hear at the back.
With the transillumination, what differences do you see on different skin tone babies?
Not so much difference. So my background is mainly in rural and regional areas. I've worked in Alice Springs and Darwin, and we have a high percentage of Indigenous babies there, so that's probably where my anecdotal evidence comes from, but it's been very much the same. The smaller, the skinnier the baby, the more obvious it is. Yeah.
All right, we unfortunately don't have time for any more questions, but let's have one final big round of applause for Lauren.